Welcome to another episode from the Veterinary Medicine Digest. Today, we are delving into a critically important, often heartbreaking, and complex area of emergency veterinary medicine, head trauma and traumatic brain injury in our beloved canine and feline companions. Severe head trauma, tragically, is associated with a high level of mortality in both humans and our pet animals. Death in these patients typically results from progressive increases in the pressure exerted by tissues and fluids within the cranial vault, known as intracranial pressure. This complex condition demands immediate and aggressive intervention, and the success of the patient often hinges on the very first veterinarian they encounter after the traumatic incident. While the initial prognosis for a severely head-traumatized patient may seem discouraging due to the treacherous reputation of the injury, dogs and cats possess a remarkable capacity to recover, even compensating significantly for the loss of cerebral tissue. Our goal today is to unravel the intricate pathophysiology of these injuries, discuss the critical initial assessments, and review the cutting-edge treatment strategies aimed at giving these patients the best possible chance at a functional recovery. The landscape of head trauma in companion animals. In veterinary medicine, brain injury in dogs and cats is most frequently caused by blunt trauma, often resulting from motor vehicle accidents, kicks, crushing injuries, or animal bites. Other causes include missile injuries, such as gunshot wounds, falls, or intentional injuries inflicted by humans. In a study of severe blunt trauma cases in dogs, approximately 25% of those patients had a clinical diagnosis of head trauma. The reported mortality rates for dogs specifically suffering from head trauma fall between 18 and 24%, underscoring the severity of the condition. Traumatic brain injury is defined as a structural or physiologic disruption of the brain caused by an external force. This injury may lead to secondary changes, which can manifest as conditions like skull fractures, separation of suture lines, contusions, lacerations, and collections of blood or hematomas. The core pathophysiology. Primary and secondary injury. To treat traumatic brain injury effectively, we must first understand the mechanism of damage, which is conceptually divided into two phases: primary injury and secondary injury. This categorization, while somewhat artificial given that the process is continuous, helps clinicians conceptualize the complexity and timing of the events initiated by severe head trauma. Primary injury refers to the physical disruption of intracranial structures that occurs immediately at the exact moment of the traumatic event. This type of damage is entirely immediate and is unfortunately beyond the clinician's control. Primary injury includes direct damage to the brain parenchyma itself, manifesting as contusions, lacerations, and diffuse axonal injury. Furthermore, primary injury involves direct vascular damage, which can lead to intracranial hemorrhage, vasogenic edema, which is swelling caused by fluid leakage from damaged vessels and decreased brain perfusion. The overall extent of primary brain injury is a function of the force of impact, specifically incorporating acceleratory, deceleratory, and rotational forces stemming from both the impacting object and the movement of the intracranial contents reacting to the impact. The brain responds to injury by attempting to compensate for volume changes, following a critical principle known as the Monro-Kelly hypothesis. This hypothesis states that the contents of the rigid cranial vault, brain parenchyma, intracranial blood, and cerebrospinal fluid maintain a constant sum of volumes. If trauma introduces an increase in volume, such as hemorrhage or cerebral edema, and this expansion overwhelms the remaining component's ability to compensate, the unavoidable result is increased pressure inside the skull, known as intracranial pressure. This ability of the brain to accommodate volume increases via fluid shifts in the brain vasculature and cerebrospinal fluid pathways is called intracranial compliance, or volume buffering. However, intracranial compliance has significant limitations and rapidly decreases as intracranial pressure rises. Once this volume buffering capacity is exceeded, any further volume increase leads to catastrophic, progressively larger rises in intracranial pressure per unit of volume. This ultimately compromises the cerebral perfusion pressure, leading to ischemia and the ischemic death of brain tissue. Secondary injury is the crucial phase for veterinary intervention because it occurs in the minutes, hours, and days following the initial insult. This delayed damage results from numerous systemic and local derangements that act in concert to perpetuate and worsen brain tissue damage and contribute further to increases in intracranial pressure. The damage caused by the primary injury activates a number of interrelated biochemical pathways. A critical initial step is adenosine triphosphate depletion, which disrupts the maintenance of cellular ionic homeostasis. This energy imbalance leads to an immediate and uncontrolled sudden influx of positively charged sodium and calcium ions into the cells. This influx results in cellular swelling, termed cytotoxic edema, and depolarization. The uncontrolled depolarization then leads to the release of large amounts of glutamate, a highly potent excitatory neurotransmitter, into the extracellular environment. The excessive release of excitatory neurotransmitters causes further neuronal damage or death in a detrimental cycle called excitotoxicity. The flood of glutamate then drives further increases in intracellular calcium levels. This excessively high intracellular calcium concentration causes severe intracellular damage by activating a number of tissue-damaging pathways. These pathways include the arachidonic acid cascade, which involves the activation of an enzyme called phospholipase A2, and the xanthine oxidase pathway, which is responsible for producing oxygen-free radicals. Iron, specifically ferrous iron, is implicated here, serving as a vital cofactor in the xanthine oxidase pathway. Free radical species, such as hydroxyl and superoxide radicals, are particularly damaging to cell membranes because brain tissue is naturally rich in both ferrous iron and membranes containing high levels of polyunsaturated fats and cholesterol. Intracranial hemorrhage can also provide an additional source of ferrous iron to fuel these free radical-producing reactions. Other key contributors to secondary injury involve the production of various cytokines, such as tumor necrosis factor alpha and interleukins, which increase in the damaged brain and accelerate parenchymal injury. Nitric oxide, or NO, is another chemical mediator that contributes to secondary brain tissue damage following severe head trauma. Nitric oxide accumulation may lead to excessive vasodilation in the brain in addition to contributing to oxygen-free radical-mediated and glutamate-mediated tissue damage. The injured brain also enters a high-energy, glycolytic metabolic state, characterized by the accumulation of lactic acid via anaerobic glycolysis. This lactic acid accumulation is itself cytotoxic, leading to further damage to brain tissue. Other secondary autolytic processes induced after severe head trauma include the activation of the complement, kinin, and coagulation and fibrinolytic cascades. Systemic conditions common in trauma patients, such as hypotension, low blood pressure, and hypoxemia, low blood oxygen, are critical as they enhance the secondary autolytic processes occurring in the injured brain, worsening ischemia and further damaging the brain, and causing edema, leading to a resultant rise in intracranial pressure. Intracranial pressure dynamics, and the Cushing's reflex. The end result of both primary and secondary injury is increased intracranial pressure. Understanding intracranial pressure dynamics is fundamental to formulating logical therapy for the severely head-traumatized dog or cat. Normal intracranial pressure values for dogs and cats typically range between 5 and 12 millimeters of mercury. Cerebral perfusion pressure is the pressure gradient that drives cerebral blood flow, delivering vital oxygenation and nutritional support to the brain. The cerebral perfusion pressure is calculated by subtracting the intracranial pressure from the mean arterial blood pressure. Cerebral blood flow is directly related to cerebral perfusion pressure and inversely related to cerebral vascular resistance. In a normal animal, the brain possesses an intrinsic ability called pressure autoregulation, which maintains a constant cerebral blood flow and intracranial pressure across a wide range of mean arterial blood pressures, typically between 50 and 150 millimeters of mercury. Pressure autoregulation links systemic blood pressure changes to brain vasculature tone. If the mean arterial blood pressure rises, vasoconstriction occurs in the brain, preventing the intracranial pressure from rising. Conversely, if the mean arterial blood pressure falls, vasodilation occurs, preventing the intracranial pressure from falling. Chemical autoregulation also influences blood flow, referring to the brain vasculature's direct responsiveness to the partial pressure of carbon dioxide in arterial blood. However, severe head trauma can compromise or completely abolish this pressure autoregulation, making cerebral blood flow directly proportional to systemic blood pressure. This crucial failure highlights why maintaining optimal systemic blood pressure is critically important. When intracranial pressure becomes severely elevated, it may lead to brainstem compression, potentially resulting in a depressed mental, cardiac, and respiratory function, and ultimately brain herniation and death. This can trigger the Cushing's reflex, which is a key clinical finding indicating a potentially life-threatening crisis. The Cushing's reflex is characterized by a triad of symptoms: systemic hypertension, bradycardia, and irregular respiration. The brain's vasomotor center detects the decreased cerebral blood flow caused by the high intracranial pressure and triggers a sympathetic discharge, causing peripheral vasoconstriction to increase the mean arterial blood pressure and attempt to maintain cerebral perfusion pressure. Baroreceptors then sense this resulting hypertension and trigger a reflex bradycardia. This combination of hypertension and bradycardia, particularly in a patient with decreased mentation, signals a potential, life-threatening increase in intracranial pressure requiring immediate and prompt treatment. Other findings associated with increased intracranial pressure include a sudden decrease in mentation, changes in pupillary light reflex, and decerebrate posture, such as the opisthotonous posture with hyperextension of all four limbs, and the loss of physiologic nystagmus. Unique and severe complication: brain tissue pulmonary embolism. While increases in intracranial pressure are the most common life-threatening consequence, severe blunt force head trauma can sometimes lead to an infrequent, but highly pathological, phenomenon known as brain tissue pulmonary embolism. This rare complication is well known in human medicine, where it is called cerebral tissue pulmonary embolism, or CTPE, and usually occurs after severe head injury from incidents like vehicular accidents, gunshot wounds, or falls. It is also extensively studied in food animals after captive bolt stunning. This phenomenon occurs when fragments of brain tissue enter the venous circulation and are transported by the blood flow to the lungs, where they occlude small and medium-sized pulmonary arteries. The sources provide details of a remarkable case study involving a 9-week-old male puppy submitted for necropsy examination after a reported history of developing acute dark, tarry stool and vomiting blood before death. The gross examination revealed extensive trauma, including multiple skull fractures, mostly affecting the occipital region and base of the skull, associated with extensive regions of subcutaneous, periosteal, and subdural hemorrhages. The animal also had a major curvilinear fracture involving the left occipital, parietal, basisphenoid, and palatine bones, along with smaller comminuted fractures. Petechial hemorrhages, or small pinpoint spots of bleeding, were also noted within the right middle and caudal lung lobes. Histopathology confirmed widespread acute hemorrhage in the brain and fragmentation, or laceration, of the cerebellar folia. The definitive diagnosis of brain tissue pulmonary embolism was made upon microscopic examination of the lungs, which showed multiple small and medium-sized branches of the pulmonary arteries distended and occluded by aggregates of paucicellular material that microscopically resembled brain tissue. These emboli were characterized as amorphous to oblong aggregates of pale eosinophilic fibrillar matrix, forming a delicate web similar to neuropil, with sparsely embedded angular, rounded, or polygonal cells resembling glial cells. The gross appearance of the emboli may be visible as white tissue in major pulmonary arteries, as reported in man and food animals, but this finding may be absent, emphasizing the need for histopathology. In both human and veterinary fields, this phenomenon is believed to occur when severe head injury causes damage to intracranial blood vessels, particularly leading to the tearing of large venous sinuses, allowing fragments of dislodged brain tissue to gain entry into the circulating venous system. If cardiac activity persists after the injury, the right side of the heart pumps these particles of brain matter through the circulatory system into the lungs, where the emboli ultimately lodge in the pulmonary vascular bed. While tearing of large venous sinuses, or the tentorium, may be the entry point, entrance through smaller central nervous system veins is also speculated. In the specific case of the puppy, the large subdural blood clots found overlying the cerebellum suggested that the rupture of major veins could not be ruled out. Specialized testing, known as immunohistochemistry, was performed on the puppy's lung sections to characterize the arterial emboli further. The emboli displayed strong diffuse immunoreactivity for neuron-specific enolase, or NSE, which is a marker for neurons, but exhibited minimal and weak labeling for glial fibrillary acidic protein, or GFAP, a marker for glial cells. This pattern of immunolabeling, strong neuron-specific enolase and weak glial fibrillary acidic protein, is indicative of a gray matter origin for the emboli. This pattern was similar to that observed in the molecular layer of the puppy cerebellum, which consists mainly of unmyelinated axons, dendritic extensions, and sparsely arranged inhibitory neurons. The scarcity of astrocytes and their processes within this specific cerebellar layer could account for the rare glial fibrillary acidic protein labeling observed. This suggested that the cerebellum might have been the source of the dislodged tissue. Previous studies of emboli in cattle subjected to captive bolt stunning also found that gray matter particles displayed strong neuron-specific enolase immunoreactivity. In humans, cerebral tissue pulmonary embolism can lead to disseminated intravascular coagulation elicited by the thromboplastic effect of brain tissue, as brain matter is rich in tissue factor, which is a primary physiological initiator of coagulation. This release of concentrated thromboplastin from the emboli can induce consumption coagulopathy and shock. However, in the canine case presented in the source, there were no gross or microscopic changes suggestive of disseminated intravascular coagulation. Given the acute nature of the vascular changes observed in the lungs and brain, it is likely that death ensued before the development of significant coagulopathies. The findings of multiple skull fractures, hemorrhages, brain injury, and microscopic brain tissue emboli in pulmonary vessels, in this case, strongly resemble human cerebral tissue pulmonary embolism and the emboli detected in cattle and small ruminants after stunning. The cause of death in the puppy was primarily attributed to the severe traumatic brain injury, with the brain tissue emboli considered a secondary change of pathological relevance, supporting even further the severity of the blunt force head trauma. This case report is significant because, to the best of the author's knowledge, it is the first documented case of canine brain tissue pulmonary embolism, closely resembling the human condition. It highlights that veterinary pathologists should be familiar with this rare finding and its implications, as better evaluation of its incidence may become possible with the increasing prominence of veterinary forensics. Even if brain matter is not visible during gross examination, histopathology is warranted for investigating cerebral tissue pulmonary embolism following severe head trauma in animals. Initial triage and emergency stabilization. Given the life-threatening nature of head trauma, initial management must be swift and prioritize systemic stabilization. Initial physical assessment must focus on imminently life-threatening abnormalities. Patients often present in a state of low circulating volume shock or hypovolemic shock, and it is crucial to address the ABCS, airway, breathing, and cardiovascular status. The clinician should not initially focus on the patient's neurologic status. Rather, a full neurologic assessment should occur only after the patient has been resuscitated and stabilized, as mentation may well improve once the state of shock is corrected. Quick assessment tests, including packed cell volume, total solids, kidney function estimates using dipsticks, and blood glucose, are integral to the initial patient assessment. Because hypovolemia and hypoxemia are strongly correlated with elevated intracranial pressure and increased mortality in human head trauma victims, they need to be addressed immediately. Fluid therapy. Addressing hypotension. Hypotension, or low blood pressure, is a disastrous event for the injured brain. It has been repeatedly shown to be a reliable predictor of sustained elevations of intracranial pressure and increased mortality in human victims of head trauma. Therefore, blood pressure must be restored to normal levels as quickly as possible. Recommendations to limit the volume of fluid administered to victims of severe head trauma due to concerns that aggressive intravenous fluid therapy might exacerbate brain edema are unfounded and strictly contraindicated. There is no debate over the disastrous consequences to the injured brain if hypotension is allowed to persist. Human guidelines recommend maintaining a systolic blood pressure of at least 90 millimeters of mercury. A retrospective study of people with severe brain injury found that a single episode of hypotension, defined as systolic blood pressure less than 90 millimeters of mercury, was associated with a 150% increase in mortality. The optimal fluid choice for resuscitation remains uncertain, but the goals of therapy are the rapid reversal of hypovolemia, prevention of low blood pressure, and maintenance of cerebral blood flow while actively avoiding increased intracranial pressure. If the patient is anemic, a whole blood transfusion may be necessary to maintain normal circulating volume and adequate tissue oxygenation. Colloids and hyperosmolar agents. Specific fluid types, particularly colloids like hetastarch and hypertonic saline, have been shown to afford a degree of protection to the swollen brain, even if large volumes of crystalloids are subsequently administered. Hetastarch, a high molecular weight branched polysaccharide, can be administered at a dose of 10 to 20 milliliters per kilogram to effect for shock in dogs. Hetastarch improves both mean arterial blood pressure and cerebral perfusion pressure without worsening brain edema. A key advantage is its long intravascular half-life. For cats, hetastarch should be administered in smaller, 5 milliliter per kilogram increments over 5 to 10 minutes to avoid nausea and vomiting. Hetastarch is considered the fluid of choice by some authors for restoring normal blood pressure in head trauma victims. Hypertonic saline, often 7% strength, is also a highly effective choice for fluid therapy in the head trauma victim, administered at a shock dose of 4 to 5 milliliters per kilogram given over 3 to 5 minutes. Hypertonic saline is a hyperosmolar agent that improves both mean arterial blood pressure and cerebral perfusion pressure and actively protects against increased intracranial pressure. It operates by rapidly increasing blood osmolality, which shifts fluid from the interstitial and intracellular spaces into the intravascular space, allowing for the administration of smaller volumes. This mechanism, along with promoting volume expansion and improved cardiac output, makes it ideal for hypovolemic patients. However, its duration of action is short, lasting only 15 to 60 minutes. Theoretically, hypertonic saline may lead to increased compromise in focal areas of damaged brain tissue or may disrupt the blood-brain barrier. Isotonic crystalloids, such as lactated Ringer's solution or 0.9% sodium chloride, are generally administered to effect. The starting doses are typically 90 milliliters per kilogram per hour for dogs and 60 milliliters per kilogram per hour for cats for shock. Because overhydration with crystalloids is a concern due to the potential for worsening brain edema and increased intracranial pressure, these solutions should be given to effect, and administration should be tapered once normal volume and mean arterial blood pressure are achieved. If colloid solutions are unavailable, crystalloids should still be administered, but not sparingly, as maintaining normal blood pressure must be prioritized over preventing brain edema. Hyperosmolar agents. Mannitol and hypertonic saline are routinely used to reduce intracranial pressure once adequate perfusion is achieved. Mannitol acts as an osmotic diuretic, expanding plasma volume and causing a reflex vasoconstriction of brain vasculature that reduces intracranial pressure within a few minutes. This reflex response is linked to the brain's pressure autoregulation mechanism. Mannitol's osmotic effect, shifting fluid from the brain interstitium into the vasculature, begins within 15 to 30 minutes and lasts 2 to 5 hours. Mannitol should not be administered to hypotensive patients, and volume resuscitation should precede its use. The recommended dose is 0.5 to 1 gram per kilogram, administered intravenously over 10 to 20 minutes. Repeated doses require monitoring of serum osmolality and electrolytes, and administration should be limited to 3 boluses in a 24-hour period to prevent unwanted side effects. Hypertonic saline is often favored for hypovolemic patients because it provides volume expansion along with an osmotic effect, whereas both agents are reasonable for euvolemic patients. A reduced likelihood of hypertonic saline crossing the blood-brain barrier is another proposed advantage over mannitol. If one agent fails to achieve results, the other should be considered. There is a theoretical concern regarding mannitol's use, the potential for a reverse osmotic shift with prolonged use, leading to the extravascular concentration of mannitol in the brain accumulating and exceeding the intravascular concentration, subsequently pulling water into the brain and worsening edema. However, with appropriate use, this shift is clinically unfounded and extremely unlikely to occur. Furthermore, prolonged hyperosmolar usage can lead to the brain compensating by forming idiogenic osmoles. If the hyperosmolar agent is suddenly stopped, this can cause a rebound increase in intracranial hypertension and cerebral edema. Another similar complication can arise if there is a severe disruption of the blood-brain barrier, such as due to intracranial hemorrhage, as the osmotically active molecules or the agents themselves can accumulate within the cranium and pull water in with them, causing complications. Oxygenation and ventilation management. Maintaining normal oxygenation and ventilation is non-negotiable, as hypoxemia and hypercapnia, or elevated carbon dioxide, can worsen brain injury. Hyperoxygenation is generally recommended for most acutely brain-injured animals. The patient's oxygenation status can be assessed by breathing rate and pattern, mucous membrane color, and listening to the chest. Patients should be maintained at a partial pressure of oxygen in arterial blood above 90 millimeters of mercury for dogs and above 100 millimeters of mercury for cats. Oxygen saturation values from a pulse oximeter greater than 95% are generally considered normal, reflecting a partial pressure of oxygen above 80 millimeters of mercury. Values below 89% indicate serious hypoxemia. Oxygen should be supplied via methods that minimize patient stress, anxiety, sneezing, or coughing, as these actions can increase intracranial pressure. Supplemental oxygen delivered via a nasal oxygen catheter or transtracheal oxygen catheter can provide an inspired oxygen concentration of 40% at typical flow rates. Nasal oxygen catheters are effective, but must be carefully placed no farther than the medial corner of the eye to avoid the possibility of inadvertently entering the cranial vault through a potential fracture site. Oxygen cages are generally ineffective for severely brain-injured patients because they require frequent monitoring and observation. Intubation and mechanical ventilation are necessary for patients losing consciousness or lacking a gag reflex. The partial pressure of carbon dioxide in arterial blood is the most powerful determinant of cerebral blood flow. Carbon dioxide affects intracranial pressure by regulating vessel tone. Low carbon dioxide levels cause vasoconstriction, while high levels cause vasodilation. Elevated carbon dioxide levels lead to excessive cerebral blood flow, increased cerebral blood volume, and increased intracranial pressure. Arterial blood gas measurement is the most accurate way to monitor the partial pressure of carbon dioxide. Ventilatory rates should aim to maintain carbon dioxide levels between 25 and 35 millimeters of mercury. However, recent evidence warns against the indiscriminate use of hyperventilation. Lowering carbon dioxide below 30 millimeters of mercury can lead to excessive vasoconstriction, resulting in increased cerebral vascular resistance, subsequent impairment of cerebral perfusion pressure and cerebral blood flow, and ultimately worsening brain ischemia. Prophylactic hyperventilation is actively not recommended, particularly in the immediate post-injury period, the first 24 hours, when cerebral blood flow is often already critically reduced. Indiscriminate hyperventilation can also worsen secondary injury by causing subsequent alkalosis, which shifts the oxygen-hemoglobin dissociation curve and decreases oxygen delivery to the tissues. If increased intracranial pressure must be addressed, short-term conservative hyperventilation, maintaining carbon dioxide above 30 millimeters of mercury, may be cautiously employed as a rescue therapy. The goal for severe traumatic brain injury should be normoventilation, maintaining the partial pressure of carbon dioxide between 35 and 40 millimeters of mercury. Positioning and temperature control. Proper patient positioning is a non-pharmacological means of mitigating intracranial pressure. Keeping the head slightly elevated, generally between 15 and 30 degrees, assists in lowering intracranial pressure and improving cerebral perfusion pressure. This positioning increases venous drainage and cerebral perfusion without compromising cerebral oxygenation. Using a rigid backboard is advised to ensure that the neck is not kinked, which would otherwise compress the jugular veins and lead to an increase in intracranial pressure. Temperature management is also essential. Preventing fever is a basic component of care, and elevated temperatures should be treated if they exceed 103.5 degrees Fahrenheit. Therapeutic hypothermia, maintaining a core body temperature between 32 and 34 degrees Celsius, has been investigated for its neuroprotective properties, primarily by inhibiting destructive mechanisms that lead to secondary injury, such as excitotoxicity, inflammation, and free radical formation. It is thought to provide beneficial results, mainly by inhibiting the release of inflammatory cytokines and glutamate, and reflex vasoconstriction of brain vasculature may also contribute to its intracranial pressure-lowering effects. It may be a viable treatment option for canine and feline head trauma victims. Hypothermia induction is known to reduce the metabolic demands and energy requirements of the brain, allowing it to better tolerate hypoxia. However, inducing hypothermia carries risks, including coagulopathies, reduced healing, electrolyte abnormalities, cardiac arrhythmias, and potential infection. If the patient is inadequately sedated, the physiological stress of cooling can paradoxically worsen intracranial pressure by causing hypertension and catecholamine release. Due to a lack of high-quality evidence in human medicine, it is currently only recommended as a last resort option for refractory intracranial hypertension. In veterinary medicine, there is only a single case report describing its use in a dog to manage severe seizures. Hypothermia in these patients should be maintained at a core body temperature of 32 to 34 degrees Celsius. Assessment, grading, and prognosis. After systemic stabilization, a complete neurologic examination should be performed. Initial assessment focuses on mentation, brain stem reflexes, and motor activity using validated scoring systems. The Modified Glasgow Coma Scale, often abbreviated as MGCS, is the most commonly referenced system for rapidly assessing neurologic status and predicting outcome in dogs. This scale evaluates 3 categories: motor activity, brainstem reflexes, and level of consciousness, with each receiving a score from 1 to 6, yielding a total score between 3, least likely to survive, and 18, normal. A patient's score is found to be linearly related to the probability of survival. Studies have shown that a score of 8 within the first 48 hours of hospitalization correlates approximately to a 50% probability of survival for dogs. A lower score generally suggests more severe injury, where severe injury is typically defined as a score between 3 and 8. Patients who are comatose with absent brainstem reflexes from the moment of impact are generally less likely to recover than patients who are merely stuporous, with intact brainstem function. However, prognostic conclusions should not be hastened based solely on initial appearance. The Animal Trauma Triage Score is another severity scoring system that evaluates 6 body systems, graded from 0 to 3, with a maximum score of 18. In dogs with head trauma, a score of 9 approximated a 50% probability of survival. A recent retrospective study determined that a decreased modified Glasgow Coma Scale score was the strongest predictor for non-survival, although poor perfusion and a higher Animal Trauma Triage score were also associated with a worse outcome. Imaging is crucial for diagnosis and treatment planning, especially in patients who fail to respond to aggressive medical therapy or who deteriorate. Computed tomography, or CT, is the preferred modality for acute head trauma imaging. Computed tomography is preferred over magnetic resonance imaging, or MRI, for several reasons. The images are acquired much faster, which is a significant advantage in the critical patient scenario. It is considerably less expensive, and acute hemorrhage and bone are better visualized. In dogs specifically, abnormal computed tomography findings, such as fractures, brain edema, and mass effect, were found in all examined patients within 72 hours of trauma, indicating its suitability as a rapid diagnostic tool. Imaging is essential because skull radiographs are often unlikely to reveal clinically useful information in cases of severe head trauma, although they may occasionally show depressed fractures. The presence of skull fractures alone does not predict survival. However, the presence of intracranial hemorrhage and lateral ventricle asymmetry are significantly and negatively associated with short and long-term survival, respectively. Based on computed tomography findings, a novel prognostic scoring system for dogs, called the Core Computed Tomography Score, was developed. This 7-point scale assigns points based on specific computed tomography abnormalities, with higher scores indicating the poorest prognosis. 1 point is given for the presence of hemorrhage, midline shift or lateral ventricle asymmetry, cranial vault fracture, and depressed fracture. An infratentorial lesion, or lesion affecting the brainstem or cerebellum, is assigned 3 points due to its severe negative correlation with survival, as brainstem injuries severely affect prognosis. Studies suggest that a core computed tomography score of 3 points or less is associated with survival with high sensitivity and specificity. It is important to remember that most dogs surviving to hospital discharge have a good quality of life long-term, with owner assessment of recovery generally being good to excellent 6 months after the trauma. However, prognostic resources for individual patients remain limited, and the perceived prognosis given by the clinician can unfortunately influence the owner's decision regarding humane euthanasia. Pharmacological treatment options, specifics, and controversies. In addition to fluid resuscitation and oxygen management, several specific medical therapies are employed. Proper physical therapy and nutritional support are also vital to a positive outcome. Mannitol is a mainstay of therapy due to its proven efficacy in reducing brain edema and intracranial pressure. Its primary mechanism is reflex vasoconstriction of brain vasculature due to decreased blood viscosity, allowing for improved cerebral perfusion pressure at a lower intracranial pressure. It also acts as a free radical scavenger. Typical dosing is 0.5 to 1 gram per kilogram, administered intravenously over 10 to 20 minutes. Repeated doses require monitoring of serum osmolality and electrolytes to prevent complications like renal failure. The maximum recommended administration is 3 boluses in a 24-hour period to limit side effects. Corticosteroids have a traditional role in treating central nervous system trauma, but there is little evidence to support their use in severe head trauma victims. Standard dosing protocols are particularly unlikely to benefit brain-injured patients. In human trials, corticosteroid use, particularly the high-dose methylprednisolone protocol, demonstrated an increased risk of death. Given the lack of equivalent studies in dogs and cats and the strong negative evidence in human medicine, steroids should generally not be routinely used for the acute treatment of traumatic brain injury in companion animals. High-dose methylprednisolone might be considered as an adjunctive treatment only in patients who are not hyperglycemic and are not responding adequately to appropriate resuscitative measures and mannitol administration. Analgesia and sedation are critical because pain and agitation increase the cerebral metabolic rate, which elevates cerebral blood flow, cerebral blood volume, and ultimately, intracranial pressure. Opioids are the analgesic of choice due to their cardiovascular sparing properties and reversibility. Continuous rate infusions of full mu agonists, like fentanyl, are preferred over bolus administration to provide consistent analgesia and avoid adverse effects associated with high blood levels. Propofol is often used for initial sedation and contributes to reducing intracranial pressure by decreasing cerebral blood flow and mean arterial pressure. Propofol may also be neuroprotective. However, it provides no analgesia and can cause hypotension and hypoventilation, requiring careful titration. Ketamine has seen renewed interest. Previously, it was contraindicated due to concerns about increasing intracranial pressure, but more recent literature does not support this concern in the context of traumatic brain injury. Ketamine is relatively cardiovascular and respiratory sparing, may offer neuroprotective effects by inhibiting the NMDA receptor, and may be a useful adjunct. Benzodiazepines, such as midazolam, are valuable adjuncts as they provide anxiolysis and sedation with minimal negative effects on the intracranial, cardiovascular, and respiratory systems, enabling dose reduction of other agents like propofol. Inhalant anesthetics should be titrated carefully and are contraindicated if intracranial pressure is increased, as they can cause dose-related increases in intracranial pressure at higher concentrations. Total intravenous anesthesia, such as with propofol, is recommended in these high-risk patients. High-dose barbiturates, like pentobarbital, have been advocated as a last-ditch effort for refractory intracranial hypertension to decrease metabolic demands, but carry risks of hypotension and obscuring neurological exams. Anticonvulsants are necessary if seizures occur, as seizure activity can worsen secondary brain injury by increasing metabolic demands and intracranial pressure. Seizures are common, with up to 10% of canine patients with traumatic brain injury experiencing them in the hospital. In dogs, the risk of developing epilepsy within a year increases with the severity of the traumatic brain injury. Immediate or early seizures, occurring within the first week, are believed to be a direct reaction to brain damage, while late seizures, occurring after 7 days, are thought to result from secondary effects like cortical scarring or reperfusion injury. In humans, anticonvulsants are recommended for the first week to reduce early seizures, but their prophylactic use in patients who have not yet seized remains controversial in veterinary medicine. The sources suggest the use of antiepileptic medication only once the patient has exhibited seizure activity. If seizures develop, emergency treatment typically involves benzodiazepines followed by a maintenance antiepileptic medication, such as levetiracetam, complicating systemic derangements. Severe head trauma often introduces systemic complications that drastically affect outcome. Hyperglycemia is a common finding, resulting from a stress response to injury, specifically a sympathoadrenal response that elevates catecholamines and cortisol. The degree of hyperglycemia is strongly associated with the severity of head trauma in both dogs and cats. Dogs and cats with moderate to severe traumatic brain injury had significantly higher blood glucose concentrations compared to those with mild injury. While the degree of hyperglycemia reflects injury severity, retrospective studies in dogs and cats have not established a direct association between hyperglycemia at admission and ultimate outcome, whether survival or death. However, based on experimental data, hyperglycemia can exacerbate neurologic injury, particularly ischemic brain damage, by increasing cerebral acidosis during ischemic periods. The provision of extra glucose to the ischemic brain helps fuel anaerobic glycolysis, increasing brain lactic acid, which causes further brain damage. Therefore, clinicians should make efforts to prevent iatrogenic hyperglycemia by avoiding unnecessary dextrose solutions and medications like corticosteroids, which could exacerbate the condition. Hyperglycemia is an indication of the severity of the injury, but studies do not support aggressive insulin protocols in veterinary patients due to the risk of hypoglycemia. Hypernatremia is another electrolyte abnormality associated with head trauma, potentially caused by central neurogenic diabetes insipidus, which is a complication of primary or secondary injury to the pituitary gland or hypothalamus. In a study of dogs with traumatic brain injury, hypernatremia, defined as sodium levels above 149 millimoles per liter, was found in 37% of patients. While overall, sodium levels did not show a significant correlation with survival, dogs with the most severe hypernatremia, defined as sodium levels above 160 millimoles per liter within the first 24 hours, had a 100% probability of dying in that specific study. This suggests that severe hypernatremia might be a strong negative prognostic indicator in severe cases. Coagulopathy is another critical concern, resulting from complex pathomechanisms involving tissue trauma, shock, and inflammation. In a study of dogs with traumatic brain injury, there was a strong negative correlation between a prolonged partial thromboplastin time and a low modified Glasgow Coma Scale score. There was also a moderate positive correlation between a decreased prothrombin time and a low modified Glasgow Coma Scale score. This suggests that coagulopathy, known in human medicine to be a consumptive process involving tissue factor release and platelet dysfunction, may serve as a useful prognostic clinical biomarker in canine traumatic brain injury patients. Cardiac arrhythmias associated with head trauma have been reported. The sources describe a case of a 5-year-old Chihuahua struck on the head with a golf club, leading to signs localized to the left cerebrum or thalamus, with probable rostral medulla involvement, confirmed by magnetic resonance imaging to have subdural and intraparenchymal hemorrhage with edema. On the 3rd day of hospitalization, for episodes of non-sustained atrial tachycardia were documented, though the arrhythmia resolved without specific treatment within 24 hours. This is noted as the first documented case in veterinary medicine of an arrhythmia following isolated head trauma. The mechanism is thought to involve the brain-heart connection, where head trauma triggers an autonomic storm and the release of catecholamines, leading to increased intracellular calcium concentration in the heart and subsequent arrhythmias and myocardial damage. Given the significant clinical impact of this association in human medicine, close cardiac monitoring is warranted in veterinary patients experiencing head trauma. Surgical intervention and advanced monitoring. While medical stabilization is the first line of defense, surgical intervention is necessary for some patients. Indications for surgery include open skull fractures, depressed skull fractures associated with neurologic impairment, and the retrieval of potentially contaminated bone fragments or foreign material lodged in the brain parenchyma. Surgery is also strongly considered for cases with focal intracranial hemorrhages, such as epidural, subdural, and intraparenchymal hematomas. Subarachnoid hemorrhage, although common, is rarely of clinical concern. In cases where aggressive medical therapy is failing and the patient is deteriorating neurologically, surgical removal of focal hemorrhage is an accepted practice. Additionally, decompressive craniectomy, the surgical removal of a flap of skull that may be replaced later, may be performed to relieve refractory intracranial hypertension. Combined craniectomy and opening of the dura mater have been shown to result in dramatic decreases in intracranial pressure in normal dogs and cats. Surgical intervention should be strongly considered for head-traumatized dogs and cats whose neurologic status worsens despite aggressive medical care. With the increased availability of computed tomography facilities for dogs and cats, surgery may begin to play a larger role in the management of canine and feline head trauma. Intracranial pressure monitoring. Monitoring intracranial pressure directly influences treatment decisions in human traumatic brain injury management, aiming to keep intracranial pressure below 20 millimeters of mercury and cerebral perfusion pressure at a minimum of 70 millimeters of mercury. While intracranial pressure monitoring is standard in humans, it has only recently been investigated in dogs and cats. A fiber optic monitoring device, capable of measuring intracranial pressure directly from the brain parenchyma, has been demonstrated to be reliable and technically easy to place in dogs and cats. While the extremely high cost limits the use of fiber optic systems in veterinary medicine, less expensive epidural monitoring systems have been evaluated. The eventual goal is for intracranial pressure monitoring to become an integral part of head trauma management for veterinary patients. Indirect assessments, such as measuring the dilation of the optic nerve sheath diameter via transocular ultrasound, are also being explored as potentially more accessible options, though this method is not yet validated for assessing intracranial hypertension in dogs. Nutrition and gastrointestinal care. Traumatic brain injury is associated with a hypermetabolic and hypercatabolic state, making early nutritional support essential. Early enteral nutrition helps maintain the integrity of the gastrointestinal system, improves immune function, and lessens the body's metabolic stress response. Brain-injured patients are at increased risk of gastric ulceration and bleeding due to stress. Therefore, ulcer prophylaxis using proton pump inhibitors or histamine 2 receptor antagonists is recommended. When choosing how to provide nutrition, the risk of aspiration and the patient's ability to protect their airway must be considered. Esophagostomy tubes are well tolerated and provide a long-term feeding option. Parenteral nutrition should be considered for patients at high risk for aspiration. Administration of a prokinetic, such as cisapride or erythromycin, is recommended to mitigate gastroparesis, which is common in these patients. Long-term outlook. The overall prognosis for victims of severe head trauma is often considered guarded to poor. However, the recuperative ability of brain-injured dogs and cats is tremendous, and aggressive therapy can succeed in many seemingly hopeless cases. While prognostic predictions are difficult for an individual patient, factors such as the level of consciousness, presence or absence of brainstem reflexes, age, and extent of concurrent injuries are influential. Patients who are comatose with absent brainstem reflexes from the moment of impact are less likely to recover than patients who are merely stuporous with intact brainstem function. The majority of complications associated with severe head trauma, including coagulopathies, pneumonia, fluid and electrolyte abnormalities, and sepsis, are treatable or preventable with vigilant care and monitoring. This has been a comprehensive look into the delicate balance required to manage severe head trauma, ranging from the intricate biochemical cascade of secondary injury to the specific challenges of fluid management and the critical need for monitoring intracranial pressure. Understanding the Monro-Kelly doctrine, recognizing the Cushing's reflex, and utilizing objective prognostic indicators like the Modified Glasgow Coma Scale and specialized imaging are paramount to improving survival rates and quality of life for our patients. The journey of a head trauma patient is often long and requires intensive, dedicated care, but the remarkable ability of dogs and cats to recover makes every effort worthwhile. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.